everybody. Hello. Hi. We're going to get started with our last session. I know that it's been a long day, and I know for some of us we still got some time this evening, but I didn't want to say we're going to save the best for last, but I think after being together for 3 days, this is a good time to have this conversation. I just want to make you aware that there is a Harvard implicit bias survey that if you feel you want to go in and kind of see where you're at as far as your biases with life, it's a great tool that you could use. So I want to go ahead and let you know that that is actually a link that's on your web page. So what we're going to do is we're just going to go over some dialogue of some research and literature reviews that I did about stigma and biases, and I tried to make them pertaining to sickle cell, but it doesn't all pertain to sickle cell. And then I thought what we would do as a wrap up is I wanted the team to come up here because each person has had different experiences, and I want it to be a genuine conversation, and I want to get some feedback from all of you of maybe how we can do things a little differently or a little better. And hopefully I talked to Kyle and everyone last night, and we're kind of hoping that we can probably bring some good dialogue to the table today. So I know everybody's tired. Hopefully you can hang in there with us, and that's kind of what we're planning on doing. So, you know, when I started in sickle cell in 2009, the first conference that Dr. Smith said, yes, you could go ahead and go to was the SCDA conference, and it was in Orlando at the time. So I am Italian-Hungarian, so my mother's full-blooded Italian. My grandfather's from Sicily, Italy. I had no idea that my family could have possibly been carriers of the sickle cell trait. Here I am, you know, been around for a while, had no idea. So when I go to this conference, the poster child that year was a young white girl with blonde hair and blue eyes. And both of her parents were of Mediterranean descent. And how about me? I'm walking in there thinking, I know everything I need to know after working here a whole 9 months. I didn't know anything. But these are now the faces of sickle cell. And of course, in this country, predominantly it is an African-American disease. I don't know if now we still have any Caucasian patients. I know at one time we had twin brothers. So, okay, so you guys do have a couple. And there's usually maybe 1 or 2 in pediatrics, right? Okay. And we definitely have the Middle Eastern population here at VCU, so we've come across that a little bit. But if you look at this, I really wanted to try to capture all the faces of sickle cell because all of us assume certain things and then we find out something different. So again, I'm mentioning this little test that was done here by psychologists at Harvard, the University of Virginia, and the University of Wisconsin that created the Project Implicit to develop hidden bias tests to measure your unconscious bias. And you're going to find through the talk that we have today how early in life, through our family connections, biases are really established. And sometimes how easy they are to change, and other times how easy they are not. So again, most of us are the way we are because of who our families are. So stereotypes is an exaggerated belief, image, or distorted truth about a person or group. A generalization that allows for little or no individual differences or social variation. Stereotypes are based on images in mass media or reputations passed on by parents, peers, and other members of society. Stereotypes can be positive or negative. And I know from talking to many sickle cell patients, we all understand that you feel that many times you're stereotyped, especially when you go into the emergency room. We're working on it. You know, we're making some progress, especially here at VCU, but those are things that we have to continue to move forward in as far as society. We're not going to change all the things going on in society, and I think Joan alluded to things a little bit earlier today that sometimes we feel like we're going backwards, but it is still something that we need to be aware of, and that all of us in some way probably stereotype something, whether we consciously or unconsciously know that it's there. If you're walking down the street and you grab your purse because you see an African-American male coming, that whether you do that consciously or unconsciously, it's still something that you do for whatever reason. Or if you're walking down the street and maybe you see somebody that's homeless and you're afraid they're going to reach out and ask you for money, you might shy away from that, or you might go to them depending on what your feelings are about people that might be in the homeless situation. So this is a very quick exercise. I just wanted to know what your thoughts would be as far as how you think that this particular exercise would stereotype somebody. So assume that a culture has had the following stereotype. Women are excellent at math but have poorly developed writing skills, while the opposite is true of men. In which testing situation would you expect stereotype threats to impair the performance of men? What do you think? A. So, prejudice is also an opinion, a prejudgment or attitude about a group or individual members, and a prejudice can be positive, but in our usage refers to a negative attitude. Prejudice are always accompanied by ignorance, fear, or hatred, and prejudice are formed by a complex psychological process that begins with attachment to a close circle of acquaintances or an in-group such as a family. Prejudice is often aimed at out-groups. So in some discussion, what do you think that means? Where'd my microphone go? I think the battery's dead. So I'd like to just have some feedback. Oh, we got a new microphone? I'd like one or two of you to please tell me what you believe that that could mean. And, no pressure, but nobody? Yes. So when prejudice is often aimed at an out-group, what does that mean? Not like you? Nobody looks like me. Nobody looks like you. That's right. And we know that we hear that a lot, don't we? We hear that a lot, not only just in sickle cell patients, but in general, we hear sometimes people referring to that, no, you don't understand, you can't possibly know what I'm feeling, you haven't been in my shoes. Well, maybe some of that's true, but that's the feelings that they've developed over time. Discrimination is behavior that treats people unequally because of their group membership. Discriminatory behavior, ranging from slights to hate crimes, often begins with negative stereotypes and prejudices. And this is a very sensitive topic. Just like this whole discussion is very sensitive. I have to tell you, at first I was a little nervous about presenting it because I didn't want anyone here to feel in any way that we were trying to talk about things that made people uncomfortable. But this is something that many people face in various parts of their lives, and in particularly African American males face it the most. Okay? That's reality. So, we are living in a discrimination type of society. And we have been for a very, very long time. So how did we get to this place? Where'd my psychologist go? I'm going to tap into you a little bit over there. She's like, wait a minute, I didn't sign up for that.
We're distracted by the smell. Yeah. On fire.
Oh. Is the building on fire? It's a drill? Oh, the grill. Oh, I did see the guy with the top up at the break time. Okay. Are we okay then, or do we need to evacuate? Okay. Look, I'm so busy talking. I smell something, but I don't even think it's anything.
It's just a grill outside. It's fine.
Yeah, I saw the gentleman grilling. He looked like he was causing a big fire at the time, So social scientists believe that children begin to acquire prejudices and stereotypes as toddlers. What do you all think about that? Do you think that that could be accurate? Yes, ma'am.
So yeah, this is actually something that if you haven't before, and you guys probably have all seen this on some form, there's a doll experiment where you take very young children and you give them a white doll and you give them a black doll and you ask them which is the good and which is the bad. and young kids. This study took place in, I think, the 60s originally. They redid it recently. Kids have not changed. They still pick the white doll as good and the black doll as bad. So kids develop the understanding that society tells them one thing very early.
So how are biases reinforced? Once learned, stereotypes and prejudice resist change, even when evidence fails to support them or points them to the contrary. So, how do you like the phrase when somebody says, "Some of my best friends are black and they're white like me"? Okay? I don't ever really hear a black person say, "Some of my best friends are white," right? So it's something that, again, in culture, I guess if you want somebody to think you're not a racist or you're not discriminating against them and you're white, that you need to tell them you have black friends. Does that sound about right? And I will tell you this. So that's a good point, but I want to also bring something else to your attention about that. And I think we were talking about this with some group, I don't know, one night this week, kind of blurry. But I remember when my children were young, and my children went to a Catholic school. Of course, most of it was Caucasian, but not all of it was. And I remember when my kids were like be driving around in cars or something, they would talk about brown people. And I said, "So what exactly does that mean to you?" Oh, I know how we had that conversation. Laura and I were talking about it. And I said, "So what exactly does that mean to you?" And they go, "What do you mean, Mommy? What does that mean?" "It just means that they have a darker tan than I do." And I kind of laughed at that. Because at that young age, they were innocent and they didn't see anything different. And then as my older son was getting in high school, he went to an international baccalaureate school. And we had friends of all races and religion at our house one day for Christmas. And some of them came in and we had discussions about the Christmas tree, and we had discussions about the churches that they went to and all the different cultural experiences they had. And it was a really eye-opening experience for me as well, because not only were we talking about people of color, we were talking about people of different nationalities. And so I feel very proud that my children have always embraced all people. And I feel that if somehow we can get our culture to get to a same place as a lot of our young children do, where they have that innocence when they're young, and they can somehow continue to see people as equals, maybe someday we'll get to a place where this is not such a country that sees people differently. That's my wish. So, outside of my bubble story, so what can you do about unconscious stereotypes and prejudices? Now, in the health field, especially when patients go to the emergency department, we've all talked about this over the last 3 days. There's a lot of things that make people think bad things about people that are sickle cell. Remember Dr. Lopato said you have to go up and get dressed up before you go to the ED so someone doesn't think bad things about you? So we have to continue to have that conversation. And one of the things that I can use as an example with our medical home and getting these committees together that yesterday we had shown you really quickly is I think we're changing some of the attitudes and beliefs of people in the healthcare system, at least here in this institution, that are working with patients with sickle cell disease. The fact that we've identified champions, people who really care enough to come together and try to fix the problem instead of make excuses for the problem, takes us in the right direction. And it took some time. I think I briefly shared the horror experience we had, the first hour we had with the ED department the first time we got together. But we were sitting there going, ooh, this was not a really good idea. And then somehow we turned the tide, and from then on, we all worked together. So it's going to take baby steps, but we're getting there, and we each have to be willing to kind of do what it takes to maybe make those things happen. So I think we're all kind of familiar with the negative stereotypes that we have. I'm not sure how much we need to get into that because many people in this room probably have experienced those on a regular basis. But we just want to let you know that, at least from our perspective, we're aware of negative stereotypes. Oh, I didn't mean to do that. And somehow, again, we're going to continue to work to change those. So I've talked about this a lot, and I think, is this something too that maybe you can chime in on? Has anybody read The Nature of Prejudice? No? So this is a book that was written, a couple decades ago, I believe. Have you read this, Dr. Smith? Where it took a study similar to what you were talking about observing children and how likely they would grow up, and depending on what their environment was when they were raised, what type of young adults and adults they may become. And of course, we all know that people who may come from situations that are more challenging than ours, not always, but at times may struggle to be able to find themselves as young people and then as adults. So that supportive, loving environment that they may have growing up helps nurture the supportive and loving environment they may have, not always, again, not everything's 100%, but may help them become more tolerant adults as they continue to grow and mature. So I also have not read this book, but when I was doing my literature review on presenting this case or presenting this segment, I thought this was a really great representation, and it's going to be in my reads somewhere down the road. So hopefully you'll kind of take a gander at it and maybe even provide us some feedback onto what you think down the road. So integration by itself has not been shown to produce dramatic changes in attitudes and behavior. Working in structured environments to problem solve through community service and attitudes about diversity can help change things. And I will also say that I think it's helped change me over the last 10 years. I've really grown and tried to recognize culture in a very different way than what I did in living in Northeast Ohio. And I share this story a lot. I know there's a couple people maybe here from the North. But in the North, we think very differently. We worry about whether you're Italian, Hungarian, Greek, Slovak, what kind of food you're going to have, where we can go stop off at the next place for pierogies. Who knows what pierogies are? Oh, I'm so impressed. So when I moved here, it was a really eye-opening experience for me. And I have to say that even after 11 years, sometimes I really struggle with some of the conversations that still go on in the South. And I recognize that it's a lot different than where I grew up. I'm not saying there wasn't racist issues where I came from, but I lived in Northeast Ohio. We were more worried about keeping the steel mills and the car industry open than we were worrying about anything else. So it's been a very eye-opening experience to me, and some of the team that works for me, including Dr. Smith, has really helped educate me on some things that maybe I didn't particularly pay attention to growing up because it really didn't impact my life. And then preliminary evidence also shows that unconscious attitudes, in contrary to initial expectations, could also be altered. Your unconscious behavior sometimes dictates how you actually act every day. Like I said, walking down the street, grabbing your purse, moving away from a homeless person, all the things that sometimes you probably don't even realize that you're doing. And I remember President Obama bringing that situation up a couple years ago when he was talking about one of the horrible crimes, I think it might have been the one in Florida, and he was talking about how even how he was, as a respected black man, he would still see women grabbing their purse when they were walking down the street. So we have a lot of work to do, and hopefully together in this room we can make some differences as we're moving forward today. So again, we talked a little bit about unconscious bias. Again, I think we all probably have it in our own way, shape, and form as to whatever that might be. And I think the biggest thing is we need to be committed to change and sometimes watch how not only what you say but how you act can give somebody a different perspective of how you might feel towards them. I have a bad habit of talking with my hands all the time. I'm Italian, as you can see, they're always flying. And I remember when I first started having some people work under me, I wasn't really aware that all of my hand movements were causing some people to feel uncomfortable. So I do a lot of my stop, wait, blah, blah, blah. And they were like finding that offensive. I didn't really think anything of it. I talk like this all the time. As you can see, my hands are waving as much as my mouth is going. But it's part of who I am. But then I had to take more of a realization that sometimes maybe I need to be less flamboyant in how I talk. Probably still doesn't work if you probably talk to anybody that works with me. But I still try to make sure I don't sit with my arms crossed when I'm talking to folks, that I maintain eye contact, that I try not to let people see something that might make them feel uncomfortable. So sometimes I have to make that conscious effort to myself to be better about how I present myself. And so sometimes it's just about presentation. You may think or feel a certain way. The lady that I had spoken about yesterday, who was our nurse practitioner for 10 or 15 years, had very different opinions politically than she did the way she practiced taking care of our patients. Did she not? She would sit in a room and she would try to convince you to vote for the other person all the time. But I can tell you right now, if those patients called her, no matter what the time, day or night was, she dropped anything for them. Because she was able to somehow separate her beliefs from her practice. And I think they really, they still miss her to this day. She's been gone, 5 years now? And they still call her. She probably knows more about the patients sometimes than we still do. But it was something that she was able to do and still be able to take care of patients that she cared enough about. Dr. Smith, is there anything you want to add about that?
Yeah, I want to tell a very poignant story about this lady, and in the process reveal a lot about both of our cultural beliefs and background. She and I both are evangelical Christians. Both of us Presbyterian. We discussed that with great joy. But one day, a student that she was mentoring and I were with her, and she said, I've been studying history, and I don't think the slaves had it so bad. That lady, by that time she had been taking care of our patients years. And I looked at her and I said, say what? And we're on the elevator, just the three of us. And she said, well, they had food and they had a place to live and stay, and not all the masters were bad to them. And I said, how can you say that and call yourself a Christian? After all these years we've been talking, and she said, well, I'm just reading and what I've learned, and this is what I think. And I said, and furthermore, how can you say that in front of this student that you're mentoring? You don't even need to bring that up in this conversation in a professional venue. You could have kept that opinion to yourself. And she could not restrain herself from her views penetrating the way she talked to patients and to employees. And the patients complained to me that she's trying to tell us who to vote for. I didn't fire her. I did not fire her. But I said, you need some boundaries on your behavior. You cannot politically, you can't have political activism as part of your job. You might have feelings. I can't stop you from having those feelings. But you can't tell patients what your attitude is about who they should vote for. I mean, she would do stuff like, this person who's in office now isn't really for your people. You shouldn't really trust that they're for your people. Again, I just, how do I reconcile what I thought was her belief system? I thought it was the same as mine. And her behavior. It was quite vexing. And to this day, we never resolved that issue. We never resolved it. And So the patients look back fondly on this person who worked for them and did a lot for them. But they also will say in the same breath, and she told us who we should vote for.
So, we're going into stigma. And again, you may take offense to how some of this is reported. But we obviously know patients have experienced lifelong barriers in access to care and treatment. That's why some of you are here. That's why our two friends from West Virginia asked to stay for our Train the Trainer, because they're the only providers in West Virginia. We realize that that's still a problem, and even like I think Marcia said from North Carolina, with all the resources they still have a long way to go. But we have champions here. We have people that have stuck it out. We've been here through thick and thin. I've been here for 10 years. I love it. I don't want to go anywhere else. And I know there's other people in this room that feel the same way. So somehow we're going to make a difference. Patients have developed mistrust of the clinical personnel caring for them. I think Dr. Smith touched on that yesterday, including African American physicians. Now, number 3, I hope you don't take offense to it, but I have a story to tell you behind that. Sometimes, even when you do your best to try to help people, they're not able or willing to maintain the services and support you give them. We have a young person right now that we're dealing with that 6 months ago didn't have all the things that she has now, including a beautiful apartment. We're trying to get her some, interest in a job. There's all kinds of different assets going on, but because of her own mental health issues and maybe her immaturity, she's just sabotaging that apartment, and more than likely is not going to be able to stay in it. Patients, families are burnt out due to lack of resources to provide care for their family members. Does anybody feel that their family member might have been burnt out in taking care of them? I think it's okay to say you are. I think as a parent, sometimes you're burnt out just dealing with children in general. And I've been fortunate to not have a child with a chronic disease. And I know sometimes, I think Stephanie said it yesterday, you have some that are doing really well, and you have other ones that, are your challenges. That's part of parenthood. But then you have on top of that, people who don't give you the resources and the things that you need for your children. And lastly, it's not just social workers, but there's limited resources to assist patients in many clinical and community settings. I was somewhere recently where I was with a social worker who worked in Los Angeles. She can't find housing for homeless people. There's nowhere for them to go. So you're sitting there saying she's going to get phone calls and people are going to ask her, where does she send patients? She has no answers for them, because there's no resources out there. Section 8s are closing down. They're not taking applications. Public housing, and for whatever better or worse, is being, many of them, demolished. So, you don't really know what to do. So sometimes you're frustrated. You're frustrated with the patient. You're frustrated with the family. You're frustrated with the resources. That's human behavior. And I think that, is it tomorrow? You're talking about burnout? There you go. So there's 4 domains of stigma, and what I want to do is I want to just go quickly through these, because I did want to have our panel come up here and hopefully have some dialogue before we leave for the day. So these are the 4 domains that have been identified as sickle cell disease stigma with adults living with sickle cell disease. Are these sounding familiar to any of you? Do these sound accurate to you? So in the literature, it reveals that stigma is a detrimental consequence for patients with sickle cell disease. I don't think we're telling you anything you don't already know. Research and practice implications were identified. I think that we all try to do what we can with research. Dr. Smith has done years of research with sickle cell disease and has made tremendous strides in literature review and some of the studies that he has, but we still have a long way to go. which of course means we still have more research we need to do. So we need to have academic medical centers like Dr. Iffy and Dr. Smith and all the other ones out there that are working with providers to continue to feel motivated to deal with research, that we have young postdoctoral students who take an interest in sickle cell disease and are going to help us with the psychosocial dynamics of the disease. That's why you're all here today, and thank you very much for that. And of course, when we're talking about stigma and we're talking about bias, somebody asked me to make a comparison. And so I went and I did a lot of literature review to prepare for this. And I'm not even sure this is still the best representation. But when speaking with the patient, what information, if they're telling you something, can you base on their reporting to know whether or not what they're reporting to you is a stigma situation as far as they are concerned, or a bias situation? That's a little challenging sometimes, isn't it? I had a couple case studies that I was looking at. One of them very clearly was racial bias. I think it actually might be in here. Let me fast forward here. It's not that one, but I want to show you this one because this one was actually published. We'll come back to that. But this was a case study about Amy. Amy was in a sickle cell crisis. And as you could read, by the time she ended up getting care, I think she had gone to 3 emergency rooms. Does this sound familiar to some of you? And she really felt in her outcome, and that story is something that you can follow up on, that she was perceived by the nurse because of the color of her skin to be a drug addict. So we try to prepare our patients by letting you know that they have individualized treatments plans. If you go out to a rural hospital somewhere, that doctor probably has no idea how to take care of a sickle cell patient. But hopefully that sickle cell patient has access to their patient portal, has access to their individualized treatment plan, or in our case, we're fortunate enough they could say, listen, I have somebody on call, you need to call them for me. They know how to take care of me. Those are the things you need to at least empower your patients to have, if at all possible, and demand an individualized treatment plan. That seems to be the way things are going today. Ask for an individual care plan. How do I get treated if I'm in the emergency room? What do you do for me if I'm on vacation? I have to go to an outpatient clinic for care. And if I'm inpatient, these are the things that my sickle cell provider is telling me that I need to have. If you don't know how to develop an individualized treatment plan, we have a sample and we can send it to you. And don't be afraid to report inappropriate and negative behavior. If you are not treated well, you let someone know that. There's a patient relations, usually someplace, somewhere that you can report something to. Yes, ma'am. We only have, I think we're down to one mic. Oh, he has one.
So I just want to comment on that real quick, being as how I've made complaints, several, unfortunately. The best and the quickest way, social media. You tweet about that misuse or whatever, oh, they sent somebody down quick time and in a hurry to address that issue. Because I used to go the way of
Patient relations.
right. That take too long. You want it done quick time in a hurry? Tweet, Instagram, Facebook, hashtag at them. Somebody will get to you. Quick time and in a hurry.
Tag it.
Oh no, that's what I'm saying. That's what I'm when I say at you tag them.
Hashtag.
Oh. Tag the university or the hospital.
In your file history, when you identify the VCU,
It links to narrative.
at VCU Health, Dr. Smith. Yes, and go again. They're right here.
And you also get a notification. So you see it, and everybody else sees it too. It can go to your portfolio.
You've never been tagged. So if you see number 4 down here, say, utilize social media. No.
Okay. I just wanted to make a quick. I just wanted to make a quick comment. I had started a program, like I said previously, in Montgomery, Alabama for sickle cell patients, then one at Vanderbilt, and I'm currently now at Johns Hopkins. So when I was at Montgomery and Vanderbilt, I really spent 50% of my time, I'd say, putting out fires, telling my patients, make sure you put in a complaint, trying to, tell the physician, no, morphine works for her, 50%. That was 50% of my job. It was so refreshing to come to Hopkins. I have not had to go to patient relations. I have not had to spend 50% of my time, trying to put out fires. It's just, I cannot tell you, it's so refreshing for me to do what I was hired to do. The team at Hopkins has worked, very, diligently and deliberately to try to dispel the myths, the bias, all of that. And when I come on the patient units, the nurses know the sickle cell patients, and they will say, oh, that's so-and-so, she likes to have her this. And I was like, how, it was just like, I'm just like, my mouth just drops to the floor.
We know
It's
how you
such a
feel. We've been
difference.
able to do most of that too.
Such a difference.
I think that most of our patient relation calls could be because someone doesn't get their prescriptions filled on time. But I think that, correct me if I'm wrong back there, ladies, is that true? Because I don't remember getting any calls about much else these days. Do you hear anything that? Oh. So maybe we need to know about that when you get it.
I'm also concerned that even when some of our patients, so not only am I in the clinic, but then I also run the community-based organization, and I get a lot of clients that reach out and say, I was traveling outside of the Twin Cities or whatever, and I've actually had pharmacists that have confiscated their prescriptions, would not give their paper back to them, and then denied that they took it, but they had sent me a photo of them doing it. I have, we always recommend that they call the clinic, or if they're traveling, have that hospital call the clinic. We have on call that have refused to call the clinic, right? So even in the midst of having these things in place, it's almost like, you almost had to have a card back in the day to show you was free. I am challenged. I'm just saying. So as much as I can argue for, I can also argue against needing to prove anything.
I understand.
And obviously we have to have solutions towards, where we are trying to go. But I don't know if anyone's seen the little PSA, little clips where the patient that comes in that had his card, but the card had fallen out of his pocket and it was under the chair, and then he went up to register and he couldn't find it, and then the video, yes. And they didn't believe him. Right. What happens when they don't have that card, or they don't have that plan, or is that then a reason for denying them? So we just have to think broader about who could this negatively impact, or what scenarios could this negatively work against.
So I think that this is one of the things, two things are happening. First of all, ASH is trying to do what they can. Dr. Smith, talked about this faculty group that we have going in November, that we're hoping over time we start finding more providers around different areas who might be willing to care for sickle cell disease. And I know it's a long road till we get to that place, but we got to try somewhere. And again, for us, I can only use us as an example. We hope that by the ECHO program that we have, that if a patient is somewhere out there in a rural area, that maybe if they've joined our ECHO, or they know that this program exists and somebody shows up there, maybe it's going to make a difference. All we can continue to do is try. And I know it's frustrating. I couldn't imagine being in that situation. But I think that us being here today is a step in the right direction, and we got to continue to do what we're doing.
But we can change people, but we're not also changing policy, because when those people retire,
get that.
When they go, it's a perpetual.
Well, you got to remember too that the fact that we have this big opioid epidemic out there has made things a lot worse for everybody. Yes, so, we have something that's exploded that has nothing to do with sickle cell. Dr. Smith got into that a lot yesterday, so I don't want to continue covering that. But we have two problems, and the patients are just caught up in the whole opioid epidemic problem. Yes, ma'am.
So just a few points, like you stated, ASH, they just had a whole lot of community engagements about, stigma and research. And just to piggy kind of back on what Brenda said, especially being at Hopkins, with, some unfortunate past things such as Henrietta Lacks and research, when people, when I go out and talk to the community and they say, you work for Hopkins, how could you do that and this and that? And it's very important, that I let them know that, like with studies and things like that, it's very important that we try to attend and get the information, because studies are so important. For example, like the gene therapies, and to help the sickle cell community. So it's very hard when I'm engaging with someone who looks at me and they're like, I feel they think that like I switched up, right? Because it's like, and I'm like, well, I have a daughter and I have a husband, and my husband, without going ahead, he's a patient at Hopkins and he does very well. And then when I tell them, I'm like, he works for the federal government, he's a football coach. Like when I say these things, they're like, and they can't believe it. Like he works every day and he coaches football.
Changing
I'm like, yes,
mentality.
because he gets great care. And we have to I engage them, and I think being at Hopkins, it can be like a catch-22, but just like you said,
But you
it's
also
very
have a
important.
great example of what Ray was just saying. You were able to take a really bad situation and be able to say that what has it been, 50, 60 years since that happened? And somehow the evolution has been that Hopkins did learn their lesson. So if we do want to change, we can't always stick with the same thing. We have to remember that in order to change things, sometimes there has to be forgiveness. It's not easy to do that. But in this case, you think about, look at where you're at. You just got done saying this is the best place you've ever worked. So they've obviously went from really, really bad to really, really good. So you got to look at that. Yes, Miss Tiffany.
Nakia said in regards to, I guess that stigma, as well as support, as well as some of the engagement, because for me, I used to work with the community blood bank here in Richmond, and I used to do a lot of public speaking and speaking to the African American population and community. So as far as blood donation. And when I go in there, and we all know that with blood donations amongst African Americans, it is the lowest. I think it's something like 9% compared to everyone else. So you go in there and you have people that say, hey, listen, yeah, the main thing and it was so frustrating to go in there, and then I'm like, listen, I have 2 kids with sickle cell, blase Skippy, this is what goes on. I need, we need blood, this, and the third. And then the first thing someone will say is, what about Tuskegee? That's the main thing, and it's like that's stuck in their head. And even now with ASH, they're trying to get more more clinical trials, but then it's hard to get the clinical trials in the African American population. I mean, let's just be honest. And then also, I mean, we can talk until we blue in the face, we can put action to it, and then we have everything, but the thing is that stigma. But also too, I think the more we engage with outside of who we have in here, the more we'll be able to reach, someone, a larger population. So that's my take.
Yeah, yes, there you go.
Okay, so if we understand the history between, I guess, the healthcare community, healthcare providers and patients, we understand, Tuskegee, mutilation of black women, all of that. Those were extreme. So if these extreme circumstances happen, it needs to, something greater needs to happen to combat that. I'm not saying anything is going to, wipe that from the memory of, black people, but That's severe.
Thank you, girl. That's what I was about to say.
That's severe. So we can't just,
I was
you know.
sitting over here like,
Right.
no.
All of this has happened, and all of
You can
these
never
factors,
dismiss justice.
Exactly. All of these factors contribute to, you know, why I may be apprehensive, because it has happened before. You know what I mean? Like, not saying, you know, it hasn't gotten better or healthcare economy isn't progressive. We understand that, but that's a lot to process, or to even believe someone could have my best interest at heart. You know what I mean? When this group of people for decades, years, has mistreated you, or people that look like you. It's not going to take, you know, a conference or, you know, one or two conversations. You have to understand, you know, the history and how that has affected how we interact with one another, because it's going to take more than, you know, just these conversations, but what can we do to combat all that has happened? Because slavery was kind of bad.
So I thank you all for your comments. And like I said, I know this is a very tough conversation. It's tough to stand up here and talk about it. But what I would like to say is that I know conferences don't solve everything, but you have to start somewhere. And so all I'm asking is that we look at the discussion, we look at people who are willing to work with sickle cell patients, and we embrace them. If I don't look like you, is that okay if I'm advocating for you? And I would like to think that it is. I had that conversation yesterday. And I asked them, I asked the two wonderful people sitting here. Can you comment on that?
Sure. No, you definitely put me on the spot. Definitely put on the spot. I have a lot of thoughts just surrounding this conversation. I think one in particular is one that's, you know, we've talked so much about sickle cell and what it looks like in a global perspective, and, you know, like, not every patient with SCD is black, you know, in the world, but here in America, the majority of us are black. So I think when it comes to the history of this nation and how that affects our care, you know, it's institutionalized racism that our genetics are built on all of the other cures that are out here for so many other diseases. And it's heartbreaking, it's devastating, it's unacceptable, it's disgusting to me. I also think that just in general, the black experience is not a monolith. You know, we're all different. We all have, you know, so many beautiful cultures and backgrounds. And sometimes being black just in general can be exhausting. I'm like light on it sometimes. So as a patient, add sickle cell to that. How exhausted am I after I come home from working all day and then be like, oh wow, you know what? My back isn't feeling too well. You know, maybe I had to take some medicine, but guess what? You know, whoever pissed me off, you know, about some issue that they may have said or statement or like that. So, but I do think that there is some type of relationships and conversations that need to be continued and had. Like I said to you yesterday, I think as long as, you know, people who, you know, when it comes to especially white people in black spaces, as someone who has attended two predominantly white institutions and just navigating those spaces, there's just a respect that needs to come when it comes to the culture and an understanding of the culture. And you're going to be met with a lot of, you know, skepticism and pushback, you know, and you're going to have to prove yourself, even if you don't feel like you need to. If you feel like you have all the credentials in the world, you've been working with this disease for 40, 50 years, what does that mean? That doesn't mean anything until I am a new patient, you know, to you. You're a new provider to me. Let me see how you're going to advocate on my behalf, and then I see you've put the work in and you actually really care about me as a person. You've put my color aside and accepted me as a person and accepted my disease as a person. And that's where that empathy comes in and that compassion comes in, and where bridges are able to be built. So I think that, you know, as a white person or a non-black person working in this space, I think there's an acceptance that's going to have to happen, as in, you know what, I know what's going to happen when I first come in, but I'm dedicated to this disease because this is what I truly care about, and I truly love these patients, and I want a universal cure for all of our patients. And it's not going to be easy, but it's worth it because I love what I do. So.
Drop mic.
So I don't know if we still want to go ahead and do the panel, or we feel we've had a great discussion here already today, but I just wanted to be able to offer the opportunity for those of us who work with sickle cell patients for you to be able to ask us questions maybe related to this or experiences that we've had. But if you feel that's too much, that's fine. We'll stop it like the way we are, and we'll move on. For those of you who need to go home, we thank you for coming. But I just need to know, does anybody want to go through with the panel, or are you all good with the discussions we had?
Yeah, I had something to say.
Sorry, I didn't see you over
No,
there.
it's perfectly fine. It's fine.
Oh, my apologies.
So I can. Did you have something? I can pass it to him.
Didn't see you over there.
Oh, I'm sorry. Look. Okay, I wanted to go more on what this well-spoken gentleman was saying about the Black experience not being a cultural monolith. So in that same regard, we shouldn't see any solution to this as a medical monolith or a health monolith where one thing is going to sweep across the board. I think also it goes without saying, I mean, we know this, but do we know this? Especially considering today's climate where equality is tossed around like lollipops. What we need to understand and also apply is that equality and equity are two different things. So you can give each kid the same, something lighthearted example, insert here. Right. We're starting at the same line, but there are often, for some of us, exactly. And so equality is not going to suffice. It's going to be justice, equity, just not like a blanket statement. The same way we're not the same culturally, we're not the same medically, we're not the same spiritually or whatever have you. So I think that is also one thing that we need to take into consideration when we're talking about dealing with this population, treating this population. We're all individuals outside of a chronic illness. Then you add that on, that's going to manifest itself. I mean, I think I'm preaching to the choir, but I really want us to understand there's a difference. We can't just toss a one-size-fits-all solution to this issue. I don't think there is such a thing. Each person should be treated with dignity according to how they feel they're having to handle this disease.
So, disagree with me if you like. I'll start there with the caveat. But Shirley, when you mentioned speaking with your hands, and you were saying you're having to kind of curb your authentic self to make other people feel comfortable, that's the Black experience. But I want to kind of flip it, because when we were talking, something came to my mind. I'm not going to say the majority, but if there are white people in the sickle cell community trying to do good work and trying to be heard, that's like you being Black in the white world. I mean, if you kind of think of it, you're trying to navigate as a minority in a majority, cultural things that you may know may not flow in that, society. And the fact that you really have to curb what maybe your normal, true, authentic self would be to connect with someone, to get them to trust you, that's life. And that's like the burden of the Black. person. Kinda. You can disagree with me. That's what I said. I agree with you.
More of like a general example that comes to mind that might be helpful in terms of just like everything that you were saying. I took a sociology class back in my undergrad, and my sociology teacher had done this really good example without like prefacing anything. She had like a garbage bag in the front of the classroom and told us to crinkle up a piece of paper and try and make a basket. And the way that the room was organized was that it was kind of like at levels. So there was people that were closer to her, and then people who were, up higher and farther away, and said, go ahead and shoot a basket. And clearly the people in the front had an advantage because they were in the front and they could make a basket pretty easily. So her takeaway was that in general, when we talk about equality, it's not about giving everybody a crinkled piece of paper to be able to, make a basket, but more so to help everyone be able to make that basket from where they are. And so that was an example that kind of stuck with me, and something that I think helps when we're trying to talk about equality and making sure that we're helping people have the same opportunity, but that might look different.
I like to say the fact that you all had a person that was trying to tell your patient who to vote for. And we know in jobs you're not supposed to talk about politics and religions and this and that, but I love looking at the news and I like keeping up to date. And I feel like America is being told a certain message. And that message is that black and brown people of color are nobodies. Now, we already know that there's a stigma and there's prejudice in America, racism and everything else. Now, we have patients with sickle cell disease who have never been treated right from 1910 until this day, over 100 years. And we need the government, and we need funding, and we need these biases and these prejudices and these stigmas to be resolved. This is 2019, and we can't have a discussion of, okay, the big thing is when you get hired, if you're a problem solver, you go put in are you a problem solver? This is what we should be about here in America this day, solving problems. And for the sickle cell community, I don't see that's going to happen anytime soon with the climate that's being created from, I'm just going to say it, our president. And it's frightening and disturbing. And I will say this, everybody needs to vote.
So thank you all. I think this was a great discussion. I thought it was a good way to end. Pardon me? Pardon me? Oh, you still want the panel? Well, it was just going to be us. Well, my one navigator ended up just leaving. My social worker went home sick, so it really would be Stephanie, Dr. Smith, and I. So.
Can we hear you guys' thoughts, or like experiences with it, unless other people?
Yeah, we're willing to do whatever y'all want.
Okay, so I'll even call Austin up here. So he was going to feel bad that he actually stepped into the room, so he could replace one of the team members. Oh, I know. You cannot have him. He's not moving to Maryland. I'll bring another chair over.
Oh, yeah.
Stephanie says she wants a lower chair.
Okay. I'll sit over here so I'm not in the
So, what do you want me to? So, does anybody have questions pertaining to prior authorization or? No. Biases and stigma.
I have a question.
So, speaking on my perspective, being hired here, this is my first official year being on any prescribing side and being here at VCU. This program has obviously been headed by an African American doctor, which raised my eyebrow. You don't typically see too many of this type of person in that position. So, but Dr. Smith has given me a good vision, and he hasn't provided me with bias. Oh, you should be on the patient side or on the doctor side. And I've never looked at it that way. In handling patients' care, I've never looked at it that way. I've looked at them as equal individuals with a disease that I don't have. So it's motivated me to be there to provide better care for them, because they're in a situation that I cannot relate to, but I want to help that situation. So
I'll continue to get personal. I think it is unusual to have an African American male in a position of power the way I am. I recognize that. It feels really good, and it does not feel burdensome. I'll get back to that one. But I want to explain how I think I got here. I think I got here because I had parents who provided a nurturing environment. My dad was a principal in a school in a little town in Alabama. He had a white, tall, crew-cut superintendent who looked like a state trooper and called him by his first name. And I observed that. I witnessed that. But he carried himself with dignity. He said yes, sir, to this man. He was able still to not feel less than and not communicate that he felt less than to me. And he had complete control over his school. My mom was second in command. She was the 12th grade English teacher, same school. I saw them in positions of respect and power, and it was normal to me to see them in those positions. As I look back, I recognize that when people called him Mr. Smith, or they called my mom Mrs. Smith, they were throwing on them major respect. That was normal to me. And I learned that I could be just like them or better. And then my parents, who did I do my one-on-one with today? She's out of the room. My number one, those 25 values. Anybody want to guess what my number one? You would think, because I talked about being an evangelical Christian. No.
Beauty.
No, you would think it was respect. No. You would think it was competence. My folks said to me, you're going to be somebody. You're going to be somebody. And they taught me that the way I was going to get there was competence, success. I spent my time growing up preparing for this job. And so I think that's why it hasn't felt abnormal for me, Austin, to go through the ladder of success that I've gone to get to the program that we have now. I expected that I was going to get there. I don't think that's true for a lot of African Americans. Am I right about that? It is not an expectation that the destination that is possible for them is probable for them.
Even more so that African American has a chronic illness.
I didn't hear you.
Even more so if that African American has a chronic illness.
Even more if that African American has a chronic illness. Now, let's talk about an exception to that rule. Who knows that the president of Howard University has sickle cell disease? So he's off the charts, right, in being an outlier. I'm not far behind him, off the charts in being an outlier. So what I'm trying to say is I recognize that the normal or the statistically expected or statistically probable outcome is something that we need to change. We want it to become normal for sickle cell patients to become college presidents. We want it to become normal for African American males to run $1 million programs. We want that to be normal. And it won't happen overnight, I get that. But we do have to start somewhere. I am agreeing with you. So my personal admonition is to all of us as we work with our patients is to try and set that expectation of competence, an expectation of success for your patient, because they're doubting, they're wondering, and they're looking around the room, and the only input they're getting back from their windshield survey is that I'm not going to make it, statistically speaking. So you have to say to them, you can be the outlier and you can make this normal, and give them little steps on how to get to the next step. I'll give the microphone to Stephanie. Somebody's got their hand up though.
I know two young ladies from our area. One has beta thalassemia, and one has sickle cell disease. And because of their frequent hospitalizations and things, their childhood ambition was to be pediatricians, hematology pediatricians. Okay. But they were both discouraged by the medical community.
I believe that. I absolutely believe that.
And well, one took another career path, doing quite well, and the other one is just starting her journey. But now, when you have your own physicians that you're supposed to be having trust in and taking care of you and doing things to prolong your life, but they're telling you, well, that's just not going to happen, that confidence and competency level just is thrown out the window. Even though your parents may tell you and other people may say you can do anything you want to do, your parents may tell you can do anything you want to do. The ones you're looking at the most is, telling you that's not going to happen.
Let's give Steph a chance to throw her hat in the ring.
As good as a program as we have, and with the things that we have going on that might not be happening other places, there's still stigma here amongst our some of our providers, especially being a teaching institution where they rotate out every year. So you have a fresh crew that has to come in, and you have to kind of get them acclimated. So it's still happening here, even with a larger population of sickle cell, and we have certain drugstores. I'll say CVS. There's a CVS on Broad Street that a lot of patients use. That CVS still will have issues depending on who's at the desk that day, at the counter. It can still have issues with getting pushback from the pharmacists getting their prescriptions filled.
Yeah.
And that's a place where they're familiar with Dr. Smith writes there. This is the kind of prescription he writes. This is not fake. This is the usual. So, I don't know.
I was just going to make a comment about what Dr. Smith was saying. It was years ago, because you know Dr. Whitten, Charles Whitten, who
Yes.
was over our national efforts for years. He was trying to get us, who were on the front lines, talking to a number of the sickle cell patients. He said, because we followed what we were being taught, first of all, that they were not going to live long enough to even to aspire to be what. And he had to change our thinking, even in talking to sickle cell family members, the patients who were coming into our office that we were in contact with. Every patient, and he turned out a large number. A pediatrician in Detroit, Michigan, turned out a large number of sickle cell patients that became physicians. Okay. And he showed us that it can be done. You have to change your thinking and what you portray to other people. You can do it. And he showed them, a number of them who said to us later at national conventions, there were a lot of times, because that is a rigorous program to go through medical school, and he challenged them, you can even overcome that. So, and that's what helped us to understand it better, because we had some biases, you know, they're not going to live long enough, so why did you take them through that thought?
Most bias is partly based on fact. You observe and you extrapolate and you form stereotypes, and then you assume that nothing's ever going to be different. That's what bias is. It's not just, bias is not fact-free. Bias distorts the facts. Bias assumes that one observation that I made is the normal observation. Does that make sense? Mm-hmm. Yeah, so you have to learn it. Kids don't have it because they have no observations. But the doll test shows that they've made some observations. And so they form their bias after making those observations. True or not true, they're making the observations, their perceptions become their reality. And so you have to set a new reality in your head. You have to make, you have to point out more exceptions and expose people to those exceptions so they start visualizing, okay, I can do this. Yes.
So, okay, you spoke on like creating this new reality, and if that's possible to like speak positivity into patients, we also have to be mindful of the negative language that we speak. Mm-hmm. And we can say, you know, a person may pose as a challenge, yes, but we use terms like, you know, this patient may be difficult, or even like what is considered difficult to physicians. Even like on a previous slide, I believe it was like bullet point 3. Okay, just an example. It was bullet point 3. Just for an example, like, okay, I understand, you know, there's going to be difficult people whether they have chronic disease or not, but what makes this person difficult, or why is this person sabotaging their care? I feel like we don't consider all of the factors of, you know, in African American with chronic disease. We don't consider, you know, family dynamic or SES or any, like this creates the person. So I may be difficult, but why am I difficult, and how can we treat or you know, treat these factors.
So going back to what Joan said and during this session, that to me is what it means to become culturally competent, or shall I even go any further, culturally sensitive. I mean, that's what it means, is to enter into that person's influence and background and community, and I mean that in the mental sense, so that you can almost experience until you really feel it. I don't know that you can grasp it from a knowledge point of view. I think there's got to be an emotional. Shirley, you tell me, does there have to be an emotional connection? Do you have to feel an emotional connection before you can say, this is how this is what their experience is like? Not that you went through the same experience. You tell me.
I'm a pretty emotional person.
Yeah. I've just observed you seemingly connecting emotionally. You're able to, empathy, you said empathy, somebody did. To me, that's emotional. I think you said that. And so, until you get that, I don't think the knowledge alone is enough to really be able to have an effective bond with your patient and really say to them, I want to help you to your next step along the journey.
I think, for someone like me, I have felt over time, I sit here and listen a lot to what you're all saying, and I have a lot of respect for what you say. I have felt over time my evolution in working with the sickle cell population. And I came in, people will look at me and they think one way of how I am or who I am and where I come from, and you really have no idea. So it's always those assumptions that you think things about people that are not true. But my story is not one that makes me look like this, okay? And so we all do things for various reasons. So I always have felt the ability to connect with patients that I worked with from the time I was a transition coordinator, even now. I mean, I do miss it. Sometimes that whole middle management thing I was telling you really stinks because you don't really get to go out anymore and connect with people that you see every day. So I do feel I am an emotional person, sometimes not always in the most professional way, but I also feel that my emotions have got me where I'm at today, and that as a result of that, if I call up so-and-so and ask them to do something as a patient, they know that I care enough about them that they're going to do something that we ask them to do. So I feel for me, as a person who is not of color, clearly I might have a tan, but I'm Italian, but that's about it. I try to look at all sides. Sometimes my feelings get hurt because I think that I still may not know the cultural barriers that African Americans face, but I like to think that I've listened enough that I can't relate to everything, but that I can try to at least be that empathetic person towards that situation. So I've said this, and I'm going to repeat it again. Even if someone doesn't look like you, if we're willing to work with the population of sickle cell patients who have no one advocating for them, give people a chance. If they don't pass your scale, that's fine. But give people a chance. Because it was really easy to probably go somewhere else and work. I worked for Dr. Smith for 4 years, an hourly job, when I could have easily gone somewhere else and worked full time and probably made more money. But I stuck by him and the program because I felt a passion for it. So that's my opinion from somebody, from a different perspective. And I just hope you will consider that.
You've been waiting.
Yeah, no, I can appreciate everything that you just said, and I can tell you that just simply being in Minnesota, being born and raised in Minnesota, or Minnesota, however you want to, it was always difficult because my mother, my father, my aunt, my uncle, my cousin are all preachers. My grandmother is a bishop. I knew more than enough people, and if I didn't know them, they surely knew me. But what my parents did do well was take us into diverse environments. Okay. So we were able to see the work they were doing within the city and within the inner city, but they also took us into environments where even people who would be considered well off, they still had issues. They still had things that were going on. So we understood that although money don't buy happiness, there is some sense of security, but they still have issues. But I say that to say, when I started our community-based organization and I was building my executive board, I got a no from almost every African American that I spoke with. And the only people that said yes, the only people that kept encouraging me to do this was not my own people. And I was crushed, like to the point of, I'm not starting this. If I can't have black people on my team, I'm not doing this. And had I maintained that attitude, we wouldn't be where we are, even as a state and in the work that we are doing. Now, since then, I still hold my people to task. I still hold them accountable. I still expect more. But I also recognize that there are different levels of allyism, right? And it goes beyond just proclaiming yourself as an ally, but your track record does mean something. I encourage people to take the implicit bias test. It is not for just one group of people. As human beings, we all have bias. And when you take it every year, you can actually measure your own growth as well. We have a physician, Dr. Stephen Nelson, who actually goes around the country speaking on medical bias in healthcare, and using our pediatric facility as an example of where medical bias lived and how it was shown. He, being a white provider, of all of the team, the sickle cell team, I am still the only black person. And I don't have the credentials that anyone else has, but I can walk into the room and connect with our patients because I look like them. Not only do I look like them, but we also have a shared experience because I'm a caregiver of a young adult. But when I first started, my biggest challenge, and it's not the social worker we have here, but my biggest challenge was the social work department, who was like, who are you? You can't do this, you can't say that, you don't have this degree, you don't have this. One day, I kind of lost my religion. And because I said, listen, what you don't have is a street degree. So all of your degrees still don't add up to walking it out in the experiences. And it was, but I also voiced, I don't have the luxury to respond in the way Ray would like to respond, because this position isn't about me, my name. This position is about the legacy of everyone who will come behind me. This was the first role, and how I respond is either going to lay the groundwork or destroy the bridge for every single person who will come after me. And if we don't think broader, if we don't think upstream, down the road, pay it for all of those things, we will not recognize that how we respond to today's challenges are impacting what's going to happen for the next generation and the next generation. Because if our forefathers were stuck in their experiences of mistreatment and injustice, so many, if not all of us, would not be here today either. And I give no pass. I give no excuse. My social worker will tell you, I will be like, anybody who doesn't look like me or the patient, could you please step out? Because there are those moments that, out cultural respect, I need to have my own conversation, right? But it is also out of that I work very hard to be the middle person in the room. I am not for the doctors, and I am not for the parent. You know what I'm for? The outcomes of your child. And so there's going to be days you like me and there's going to be days you don't, whether you are the patient in the family or whether you are part of the medical team. My job, my goal is the outcomes of that patient and to see them from being a child with sickle cell disease to an adult with sickle cell disease. And it doesn't mean that somebody said it, I am a human, I'm not always right. I have my highly cultural days that I'm like, okay, pull it in, get yourself together. But I also recognize that everyone is at a different starting place in their journey of cultural humility and cultural competence and cultural sensitivity. And because we all have these biases, you can't expect, you don't just wake up one day and you've stopped having your biases. You have to be able to acknowledge what your biases are and then intentionally move beyond them each and every day until that change comes.
Well, I think that's a great way to end today. I think this was great. Yes, ma'am. You want to say, you haven't said anything, so go ahead. I'm going to give you the microphone.
I've listened to all of you these past days, and I'm going to get teary-eyed. I'm sorry. I will never walk in your shoes. I will never have sickle cell. I will never experience the pain. I will never go through the bias and everything else that you all go through. I have to say I am very honored to sit in this room with all of you. You have opened my eyes to sickle cell more than you will ever know. I have been a nurse for 39 years in Charleston. I have taken care of 2 twin sisters with sickle cell. The only thing I ever experienced with them was them being put on pain pumps and the stigma of, oh, look, she can't stay awake, and all the things that go with that, with her being on pain medication and her having her nausea medication given around the clock and things. I did not understand what she was going through. I tried to care for her the best I could, but I also had other patients, so I was really ignorant to all the things that she was feeling besides her pain. So again, I cannot thank you all enough for allowing me to participate in this conference and to learn, and I still need to learn an awful lot about sickle cell. And I just hope that I can give the patients that we will be seeing after we get our patient load. I just hope, as I being one of the nurses that will be taking care of these people, can give honor to the sickle cell disease in my care for all of the patients that I'll be touching in the future. Thank you all very much.
I'd like to say I've been a social worker 55 years. I'll be 76 next week. And I have watched so much cultural change, but I too didn't even get to see the twins when they were sick. But I have, in my years, this change come about, and I hope it continues, and I hope it grows, and I hope we all can continue to love and respect and show dignity to each race that we come to. Thank you so much. You've taught me so much this week. Thank you.
Well, most of us will probably be reconvening here in about an hour and a half or so. But those of you that are not, please put your names on the evaluations. If you need CEUs or credits or participation certificates, I hope Donna is still out there. Is she out there still? Turn those into Donna. And the rest of you, I believe we're coming back to this room around 6 o'clock. I know we wrapped up a little bit later. Please do at least your 3-day evaluations. You won't turn those in till tomorrow when you're done, but at least try to stay up to date on everything. And again, thank you all for coming. Those of you that we're not going to see later, God bless. Hopefully we see you again. Oh, hold on. I'll let Joan do it.
Oh, are they supposed to be doing it on there? Okay. Don't forget, we have a post-test that you should be doing. Yeah. I guess they can do it from online. Yeah, it's online. So, but please do it. You'll probably hear from us. We really want to see the post-test. You will not get graded. You will not get a grade. It is really for us to evaluate our training. So please, we need your input. But you'll go online like you did previously, I think, is the way we're doing that. I don't know.